Please start. We are live, ma'am. Please start.
Manisha, hello. Hi, good evening, everyone. I welcome you all for today's webinar on Meet the Experts on Cancer Treatments Update 2024. With immense pleasure, I would like to invite Dr. Tanushri Mishra, who is radiation oncologist at Aditya Ashwini Hospital, BBRSR, Dr. Pradeep Mondal, who is consultant medical and hemato-oncologist in Medical Hospital, Kolkata, Dr. Sudeep Das, who is consultant medical and hemato-oncologist in Medical Hospital, Kolkata, and Dr. Amit Badola, who is associate consultant BLK Max Super Specialty Hospital, Delhi. So let's begin your expert talks. So over to you, Tanushri ma'am, for your talk.
Yeah, thanks, Manisha. Okay, so I'll start sharing my screen. Is it visible to all?
No, ma'am.
Okay.
Visible?
No, ma'am.
Not visible.
Ma'am, would you like us to share the screen?
Okay, you may share.
Yes, I will be sharing, ma'am. Yes, ma'am.
Yeah, sure.
Manisha, your screen is not visible. Slides are not visible.
Okay, I'm sharing again.
Please make it full screen. Yes, ma'am. Go ahead.
Okay. Good evening, everyone. Today we are having very learned members in this panel. So my heartiest greetings to all. So starting today, so my first topic will be molecular marker testing in lung cancer. So today's content will cover the cancer burden in India, lung cancer burden in India, then what are the biomarker testings done in non-small cell lung cancers, then what is the evolution in testing these markers, and at last the takeaways. So coming to the burden, according to the Globacan 2020 data, it was observed that previously lungs was the worldwide, it was the first in mortality wise. But in India, if we come to India, we can see that breast cancer is overall breast cancer is most common, come to only male, lungs comes to second, and mortality also it ranks fourth among all the means according to incidence and mortality. Lung cancer ranks fourth rank in the world in terms of its burden. So it's a huge burden, and nowadays the incidence is being increased among women, non-smokers. Like anyone can have lung cancer. We can see it may be some genetic mutation or something, that studies are going on. So coming to next. Next. So, but it's a good thing that previously, when we have started our study in this line, so we were seeing that patients were coming with lung cancer in very advanced stage, and most of them, they succumb to death within a year or two with conventional chemotherapies. All of them were given chemotherapies. Very few targeted agents were there available, and that too much costly, not pocket friendly. So it was not possible on our part to treat them. But fortunately, more than 50% of advanced cases of means all cases of non-small cell lung cancer, they are having a specific means mutation which are targetable, and FDA approved drugs are also present for them to attack that target. So we can increase the overall survival among lung cancers. And in your clinical practice, you must be experiencing that previously when patients are used to live for a year or two, now they are living more than 5 years even in real life. So these are very important, and those markers are, you all know that EGFR, KRAS, ALK, ROS, we do routinely to treat the patients. And now many new markers are coming up with a targetable agent for them to treat. So next. So the importance of biomarker testing in non-small cell lung cancer, it has been seen by several studies, and all of them, they agreed to the point. You can see the curve that the overall survival among the non-small cell lung cancer with those who are with a driven alteration and are treated with the targeted therapy, they have almost 7 months more in clinical trial than those who are not treated on targeted therapy. But in practically, in real life, we see it's much more than that. Next. So then markers, there are a lot of markers, and in every day new markers are coming to means in a clinical study in research line. But what are the markers we should ask for? Because we have to see everything, the insurance companies, then patients pocket, and logistics what we have. So accordingly, so as per the means guidelines as we follow in our clinical practice, mostly NCCN guidelines, ASCO guidelines, ESMO guidelines. So all of them, they come to the same consensus that this EGFR, ALK, ROS1, RAP-MET, but these common markers should be tested in every patient of non-small cell lung cancer. Now PD-L1 is an addition to that. Next. So how to test these markers? So first is tissue testing methods. So what are the testing methods? They may be DNA sequencing, next generation sequencing, PCR method, or RNA sequencing, or IHC, or FISH. So these markers can be tested in different methods, but later on we will come to that which is more specific and which has which is most sensitive, and in what way we can decide that which method we should order the patient to do that test. Because we have to see everything. If we are actually the paraffin embedded block is one for lifetime, so we cannot do re-biopsy again and again. So we have to be very judicious while asking for a test which will give us accurate result and without wasting the sample. So we must be very careful for that. So for common this insertion point mutations and deletions, DNA sequencing or NGS, these are preferred method. Then for fusion abnormality, we usually choose RNA sequencing panel. But for ALK and ROS, FISH and IHC both are complementary, but we have to recheck the IHC result with FISH or FISH with IHC, vice versa. Next. So what is the evaluation? We will come next. So first, preliminary diagnosis is always a tissue diagnosis. That is the best method, but sometimes it is not possible. So sometimes we take ascitic fluid, pleural fluid, like cytology kind of things, lavage. Or last is the liquid biopsy, when nothing is possible, only patient's blood or the cystic fluid, that thing is taken. So that after collecting the sample, they have been prepared like to the paraffin blocks, and sometimes they go for the histology, cytology, and then after that the molecular marker testing comes. So during this process, this is a very systemic process where we have to follow the protocols, and we need to take the help of surgeons, pathologists, and other medical associates to do that, because we ourselves cannot do that. We can only collect some fluid or blood or something, but we cannot do for biopsy, all that. After that, it will go to the molecular laboratory for this DNA sequencing, RNA proteomics, for the test for the molecular level. Next. So biopsy, as we all know, this is the gold standard, which establishes diagnosis, determines the histologic subtype. Then the biomarker testing is done on the biopsy specimen. So histologic subtype may be squamous and non-squamous. For biomarker testing, primary tumors or the metastatic lesions are equally suitable, because we know sometimes primary tumor is not approachable for us for biopsy. Then we can go for the approachable lymph node, or any swelling, or the liver metastasis. That is important for us to know that they both are morphologically similar, so we can take sample from that also. But bone biopsy can be suboptimal due to decalcification and degradation of DNA. And liquid biopsies, that is cell-free DNA in plasma, are another option. But preferably tissue biopsy is taken. Then for EGFR, ALK, ROS1, and all these markers for non-squamous, non-small cell lung cancer, this broad genetic mutations, alteration, and rearrangement, they all can be tested under one heading, that is next generation sequencing NGS, to detect all the panel of the markers. We'll go to that step by step. Then PD-L1 testing is very important in all non-small cell lung cancer, because now we are having very good number of PD-L1 inhibitors which are available to patients with affordable price, so that it also been seen to be helpful in clinical practice. So we have to do PD-L1 testing also. So all this should be done between 2 weeks, that is 10 working days from the patient comes to you. So next. Now, this circulating DNA testing has potential to be applied all across the stages of non-small cell lung cancer throughout the treatment pathway. Previously, we knew that in all liquid malignancies, we used to do this MRD. But now, scenario has changed. So it has also come to solid tumors also. So in head and neck, lot of papers are there. In lungs also, a lot of paper are there. So what they do, that for the diagnosis and treatment, this genotype is recommended for clinical use in advanced non-small cell lung cancer to guide the treatment selection under specific circumstances only. It is not done routinely. In resectable cases, it's not a part of clinical trial, because if the tumor is resectable, we should always go for tissue. Then for monitoring and prognosis, response to treatment and progression of relapse, yes, it has potential applications in that. Then for the testing, overcome some major challenges associated with tissue testing. In that scenario also, it is used. It is a minimally invasive procedure that allows serial biopsies if needed. Then ctDNA in bloodstream is comprised of blood forms all tumor sources in the body. So it will capture all the tumors present in your body, not that the only one we are seeing. That might be some occult metastasis which we can know from this ctDNA. So ctDNA testing, it will never replace the tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer. Next. So, what is the take home is that it has this it has been conducted a study, that TRACER-X study, where 24 early stage non-small cell lung cancer patients, they were followed after resection, and phenotypic ctDNA profiling was done. So out of 14 patients, 13 with disease recurrence were MRD positive, and 90% of the patients, that is 9 out of 10 without recurrence, were MRD negative. So from this, we can conclude that presence of MRD may be used to predict the disease recurrence. So currently, MRD cannot be identified only using the traditional diagnostic methods. So as detection of ctDNA in the plasma indicates the presence of the residual tumor, it can be used to measure the MRD. So in this study, this ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by the standard imaging. So it's an advanced thing that we can pick up the disease before its recurrence to the to a visible form. If we do a ctDNA, we can see the MRD. Next. So what are the differences between tumor tissue and liquid biopsy? So sample acquisition in tumor tissue, always it's a surgical invasive procedure. We need the help of surgeons, anesthetists, and radiographer, intervention radiologist. So all those we need for sample acquisition, but liquid biopsy is a simple blood draw method. Only 10 ml whole blood is drawn. Then repeat sampling is very difficult and challenging because patients is at risk, because lung cancer patients, they're always having a respiratory compromise, so it's not possible for them to undergo even minor surgeries again and again. But for liquid biopsy, repeat sampling can be done as it is a minimally invasive procedure, and biology it correlates with the histology and cellular phenotype possible, and here direct correlation between the ctDNA results with the histology or cell type is not possible. It's more reflective than a practical thing. Then sensitivity of the assay require lower tumor cell content acceptable with sensitive techniques. Here, very sensitive method are required for ctDNA to comprise less than 0.01% ctDNA. So standardization uses existing validated tissue processing handling process in case of tumor biopsy. But here in liquid biopsy, standards for analytical performance characteristic of ctDNA have not been established yet. It's in its evolution phase still now. We don't have any standard protocol. So no guideline exists regarding the recommended performance characteristic of liquid biopsies. Again, the evidence, substantial evidence for the initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung cancer. But here less, but increasing evidence of initial targeted treatment selection and subsequent treatment after the targeted treatment failure in advanced non-small cell lung cancer. Next. Then coming to multiple gene or a single gene. So multiple genes are involved in this cancer, but we have to test individually each and every gene, or we should go for NGS where multiple complex genes are being tested. Next. We'll go to that next. So what are the advantages of NGS? Next. Yeah, this is very important to know, because we order NGS to the patient, it will cost more to the patient, but we should know what are the pros and cons. But it is fortunate now, the patients are fortunate that these pharma companies are providing us coupons so that it can be done at a very low cost or sometimes free of cost. But we should know where it should be used and where it should not. So as the number of clinically actionable biomarkers are increased, the ability to evaluate all known molecular alternation in a single test has given NGS a major advantage. If one or few molecular markers are needed, then higher cost and longer tumor turnaround time versus a single gene. So it is the negative part of the NGS. When a few markers are needed, we should not waste much time and money on that. But where many molecular markers are needed, it reduces the cost and it shortens the time also. So it detects a broad range of molecular alteration in a single sample and may identify new markers that could offer additional treatment options for the patient or to provide information to help the development of newer, more effective treatment. That is a very important point. Then, but it's high complex method and requires expertise persons, and it's always not possible to get access to those labs. And advancement in the field of NGS are evolving rapidly, so patients and clinical community must receive sufficient education in this area. This is a bonding area, so all should be trained in that. Next. These are the methods very much. So now coming to the individual markers. So EGFR mutation in lungs adenocarcinoma, as we all know. Next. more than 30% patients we come in our clinical practice are EGFR positive. So the sample used for EGFR mutation testings, mostly it is the fresh frozen alcoholic specimen that is used for the PCR based assays, and cytology samples are also suitable, but cell blocks are preferred over smear always because the tumor tissue would be more in the cell block. Next. NCCN guideline also, it has been mentioned that EGFR mutation results are available for adjuvant treatment decision in patients for very early stage to advanced stage non-small cell lung cancer. So it is very important. It's like if we omit that, it's a crime. We should not omit in any adenocarcinoma case to do a EGFR marker. Next. So next, coming to the ALK rearrangement. ALK rearrangement is around 93 to 100% sensitive in case of IHC as compared to FISH, but the specificity is more in case of IC, and sensitivity is with FISH. So thing is that in both ALK and ROS, if we get it by IC, we have to confirm it with FISH, or we get the vice versa, because we have to be very particular because we have two targetable agents for both the markers. Next. Yes, this is the slide I was talking about. If we get a ROS IHC positive, then reconfirm by FISH. If we get a ROS FISH positive, then also reconsider IHC for confirmation. So detection of elevated ROS1 protein levels by IHC may provide cost-effective screening. It can be used as screening, but if it comes positive, then we have to confirm it by FISH. Next. This is about the RAS mutations. So, KRAS mutations are mutually exclusive with EGFR and ALK. And it accounts for nearly 30% of lung adenocarcinomas. The most common of these arise in the codon 12 and 13. And this is very important that this KRAS G12C testing is not currently recommended because it should be performed as a part of NGS. If we get EGFR negative, ALK negative, ROS negative, everything is negative, and we need something for the patient. And now, as it's a drug, it's been mentioned that sotorasib is approved by US FDA for the patient. So we can go for NGS where we can get the result of KRAS. Next. Now, the BRAF mutation also, it is more than 50% BRAF mutation cases. They thought to have more prevalent in the smokers. So, non-mutant cases, they are less prevalent, occur 17% of patients with BRAF mutation. So, overall BRAF mutations occur 1 to 5% cases of non-small cell lung cancer, and most commonly in adenocarcinoma. All these markers are common in adenocarcinoma only. So, NGS is generally used for the detection method. Next. This is c-MET receptor tyrosine kinase. It is also it's a complex thing to do the testing. So better we should order NGS when that to RNA NGS, that is more specific than the DNA NGS, where DNA fragmentation or degeneration can occur. So RNA NGS is very important in this detection of these means rare genetic mutations where only 3 to 4% non-squamous non-small cell lung cancers occurs, but it is more common in sarcoid cases. But so we sarcomatous cases we get very less. So in our clinical practice, it is not a common thing, but when we order NGS, we get the result. Next. So for that, IC is not recommended, FISH is not recommended. PCR also DNA design dependent, RNA technical considerations are there. So DNA design dependent potentially detects many mutations. RNA is most sensitive for that. Next. Then RET receptor, it is also majority of RET fusions can detected by DNA NGS, but increased sensitivity with RNA NGS, as we see in the earlier cases. So heterodimerization of the ligand and co-receptor complex and RET lead to the autophosphorylation and downstream activation. So most common RET translocation in long adenocarcinoma is this is KIF5B RET mutation. Next. So what are the method? As we have discussed that IHC is significantly false negative results, so we should not use that. Phi is significantly false negative, so rare circumstances we can use that. But DNA NGS, yes, we can use, but RNA NGS is highly dependent upon the RNA quality. Poor quality leads to reduced sensitivity, but we can use. So majority RET fusions can be detected with DNA NGS, but increased sensitivity with RNA NGS. Next. Then NTRK fusions. So options are many like IC, RNA, or DNA NGS, FISH, and RT-PCR. So ESMO working group recommendations, a potential approach for RT-NK fusion testing is by this FISH, RT-PCR, and RNA NGS. But there is a sequencing platform not available, then we can go for other methods. But when available, we should always go for NGS. NGS versus IHC reasonably for NLCLC due to low prevalence of NTRK fusion. So important to qualify the negative results. Limitations of the sample testing is always it is important in case of any lung cancer. What is the quality of the sample? After that only we have to test the very common mutations first. After that, if everything comes negative, we should go for this rare kind of fusions. Next. So the method I see rapid results we can get it detects transcribed and translated events only. So it's a low cost single test and widely available. But FISH gives rapid results and NGS potentially for multiplex testing, less depletion of tissue, fusion partner and position and identified, and RNA NGS more sensitive. So the disadvantages are depletion of tissue, fusion partner and position unknown, less validated currently. And for FISH, depletion of tissue fusion partner and position unknown, so can be difficult to interpret. But for NGS, the disadvantage is only one thing: the little bit longer waiting time and cost. Cost is nowadays not a factor, mostly because coupons are available, but waiting time is little bit longer. So choice of assay will depend on institution, resources, and clinical context. Reflection to NGS versus IHC, reasonable for non-small cell lung cancer due to low prevalence of RTR. NTRK fusions. Next. Then HER2 mutation, only 3 to 5% cases are found to be positive for HER2, and it has a very bad kind of prognosis. So if everything comes negative, we have to do this to explain the prognosis to the patient and as well as for the treatment purpose. So IC is used for HER2 overexpression. Next. So this is the main gist of this topic, that what are the markers and what are the agents available for them. For us, very important is EGFR Cross1. Till that we have in our clinical practice, we use and we are getting results. After that, this NTRK rate, MATEX, these are not so common in our clinical practice. Even if we get the patient, he cannot afford the treatment. So these are beyond scope. I think this is beyond scope of this practical discussion. So we should always see what is the sample available for us. If we have adequate sample, we can go for one by one these first three markers at once. If nothing comes, then NGS. And if we have limited sample, only one, we can do only testing once, then we can go for NGS and we can get the result, and accordingly we treat the patient. Next. PDL1. Next. Now, as the PD-L1 antibody clones, IHC platforms and scoring systems in lung cancer is very important to know that what are the IHC platforms. We commonly know these two, Dako and Ventana. These two are used by the most common pharma companies for their drug studies. So, Pembrolizumab used Dako and Atezo used Ventana. Also, Durvalumab used Ventana. So, these are the IHC platforms where the same results come, that is either PD-L1 positive. If positive, then less than 1%, 1 to 49%. If more than 50%, then it's high. Next. So biomarkers for the immunotherapy in non-small cell lung cancer, a controversial topic, yes, because even the first point itself is about that PD-L1 is the sole current biomarker able to guide immunotherapy, but we see that sometimes PD-L1 negative tumors still respond to it. I don't know, means they are saying that maybe synergistic effect with chemotherapy, but the patients do respond. And this TMB was a former marker for the response not currently used, and conflicting correlations with survival in the checkmate studies have been seen. So MSI high, MMR not used or relevant in lung cancer, and LAG3 possibly related to resistance to immunotherapy. It's under study, it's not yet been clarified. Next. So the main conclusion is biomarker testing in non-small cell lung cancer has evolved from a single gene to multiplex testing. Multidisciplinary meeting helped in better understanding of sample and test requirements. Basically, we should involve the pathologists. They are the pillar. So pathologists, surgeons, radiologists, and oncologists, they all should sit together to decide about what tests should be ordered. Then samples should contain adequate tumor content, at least 10%, to prevent delay in the processing. And that tumor around time should be 2 weeks, that is 10 working days. High throughout platforms such as NGS can be used to screen several genes at a time to provide results within an estimated tumor around time. Next. So these are the targetable mutations, and these are the testing methodologies: EGFR by PCR or NGS, BRAF by PCR or NGS or IHC, then KRAS by PCR or NGS, ALK always by FISH. NGS is for everything. Then FISH IHC, ROS1 for FISH IHC and plus NGS. Like this, so clinical guidelines to strongly recommend broad molecular profiling to identify rare driver mutations for which effective drug may be available, or to appropriately counsel the patients about the various clinical trials. So broad molecular profiling is a key component for the improvement of care of patients with non-small cell lung cancer. Thank you for your patient hearing.
Thank you so much, Tanushri ma'am, for your wonderful talk. Now, I would like to welcome Dr. Pradeep Mondal for the next talk on overview of lung cancer. Sir, you can start.
Okay. Okay. So thank you for the opportunity. So overview of lung cancer is though is rarely discussed, because most of the time we don't give the overview. We discuss the exact topics most of the time. So this time that organizer have chosen that overview of lung cancer. Basically, that the burden of lung cancer is the first things we'll discuss. This is according to the Globocon 2020. Already madam has shown that this is the picture that in worldwide, if we see that lung cancer will come as second, but this is the Indian data, where after, hope I'm audible. Hello.
Yes, sir.
Yes,
Please
sir.
continue.
Okay. So in India, basically lung is come as the fourth common cancer and contributing almost 5.5% of total new cancer cases diagnosed. And if we see the mortality wise, lung cancer is come as second. So it's contributing almost 8% of the total mortality. Is according to the 2020. So probably in 2000, the newer Globocon data has significantly changed as in case. So basically that second most common cause of cancer in males, and after lip and oral cavity cancers. And of course that the burden is significantly high. And if we see the mortality also, according to mortality also is come as second in India. So this is the optimal staging. We have all know that staging has changed from HSCC 7th edition to HSCC 8th edition. There are some changes in that, in different stages of year. So now we follow that HSCC 8th edition, where the T4 disease is more than 7 centimeter and T3 is 5 to 7 centimeter. There are different other things. So investigative tools for staging is very important. So whenever patient comes with a lung mass, basically that we have to see that if patient has come with an very significant disease in the chest, along with there are even in CT scan there are showing the metastatic disease, have gross pleural effusion, pleural deposits. In that case, probably that will avoid doing. And if patient is having that peripheral mass, bronchoscopy may not be done. If central mass, then probably we have to do bronchoscopy for proper biopsy. And CT chest in most of the time in periphery, whenever patient is having long time cough and maybe hemoptysis, that general physician they prescribe this CT chest. In higher center, when patients come with a diagnosis of lung cancer, probably that the recent modality is PET-CT, whether it is in early stage disease or even in advanced stage disease. We prefer doing PET-CT because it gives the better idea of that uptake of that FDG, and basically that it shows that the disease burden, and where sometimes that in CT we may miss the disease in the bones. So PET-CT is preferable. EBUS is usually done where there is a chances of having a very early disease, and we are thinking of doing that surgical options as a management. So and mediastinoscopy is also present there, that EBUS after coming, that EBUS has come, that mediastinoscopy has significantly reduced. And in early stage disease where or in the advanced disease where patient is having symptoms related to the brain, then MRI brain is an important modalities that we need to exclude that brain metastasis in this process. But sometimes we see that patient may have an hidden brain mets even if patient is having very small tumors in the chest. So CCT versus PET-CT for staging, that in stage 3 non-small cell lung cancer. So lymph nodes more than 10 millimeter along the SWOT axis is the predictor of the malignancy, and CT scan alone has a very limited role due to its low sensitivity and low specificity. It may help in selecting appropriate procedures for tissue sampling by providing the images. An addition of PET-CT to CT provides the overall sensitivity to 80 to 90% and specificity to 85 to 95%. So risk factors for occult N2 is very important. It's not always detected by the imaging, already told, like that in central tumors, in that higher SUV on PET. So these tumors have very high chances of having N2 disease. So we have to exclude that N2 disease. Mediastinal staging is very important in early disease. So already we have discussed at EVAS biopsy or some invasive sometimes in mediastinoscopy. So these are the mediastinal staging. Recommended technique is EVAS or EUS. If clinical suspicion of N2 involvement remains high even after negative EVAS, in that case, mediastinoscopy is recommended. So there are 14 nodal stations usually is identified in EVAS or mediastinoscopy. So when is the invasive mediastinal staging is indicated, already we have discussed centrally located tumor more than 3 centimeter, extensive infiltration of the mediastinum with no evidence of extrathoracic disease, positive that N1 disease, or bulky N2 on CT, and in that case no need to confirmation. discrete into yes, in that case is usually done. So mediastinal staging algorithm, this is basically for surgical option. So if patient is having mediastinal lymph nodes negative, then clinically N0, low probability of the unforeseen N2 disease, negative PET CT, then surgery or radiotherapy directly. If clinical node positive, clinical node 0 and high probability of unforeseen N2 disease even after that negative PET CT, in that case tissue treatment is the option. But on this, it has been shown that different EVAS TBNI has most of the lymph nodal station as accessible. Non-invasive and invasive staging modalities. So these are the different options. CT scan, PET CT scan, the sensitivity has been shown. So VATS, of course, that is 99% sensitivity for the upper mediastinal station, lower mediastinal station, AP zone mediastinal station, hilar station. So VATS is the ultimate either. But if you see that EVAS or EVS plus mediastinoscopy, almost 94% sensitivity. Evolution of therapy in lung cancer. So non-small cell lung cancer was once considered as a single disease until the distinct subtypes and characteristics are known. Of course, that it is the era of that personalized therapy. So basically, nowadays the lung cancer is not a single disease. So it's a very heterogeneous disease. Even in the same tumors, you will find that different heterogeneous clonal populations, and it may change time to time. So it's very important that already Madam has discussed about that what's the role of doing all this molecular testing. It is basically mandatory nowadays. And nowadays we wait for the patients to these reports comes, and because that even if patient is PD-L1 positive, if patients come as EGFR positive, then probably that immunotherapy will not work. So we'll wait for the biomarker reports come if patient is not much of symptomatic. Okay, so advances in the management that basically has significantly improved the survival. If we see that the incidence wise that lung cancer has significantly increased, but of course that mortality has significantly reduced with the in this era of that molecular personalized therapy. So these are the advances basically. If we see that in the 2020 that we have lots of that that biomarkers testing available, and we have the targeted therapy like that capmatinib for the MET positive in SLC, selpercatinib for RED, rigatinib ALK. There are lots of others immunotherapies, and so there is a significant increase approvals for both targeted as well immunotherapy in NSCLC. So that of course that we have significantly improved the survival of the patient. So these are the molecular targets. Madam has already discussed in details about the molecular complexity. So in India, probably that most common that mutation which is seen is almost 30% at EGFR mutation, followed by ALK, ROS, BRAF, NTRK, MET, and RED. These are the common. There are also that uncommon mutation is also seen. So current guidelines for the neoadjuvant chemotherapy depends on the disease stage. Of course, it's very important. We have discussed in early stage disease, we have to properly basically find out the pathological stage of the disease, and according to that the treatment is planned. So in stage 1A, no lymph nodes, though that observation is the no proven benefit of neoadjuvant or adjuvant chemotherapy post surgery. And in stage 1B, stage 2A, if M0 disease, no lymph node, multidisciplinary team discusses observation versus adjuvant chemotherapy for high-risk patients, and no proven benefit of neoadjuvant. Stage 2B, adjuvant chemotherapy is recommended, no proven benefit of neoadjuvant chemo. In stage 3A, that N1 and 2 lymph node disease, neoadjuvant chemotherapy or adjuvant chemotherapy. Sequential chemo and radiotherapy is also an option for N2 or the multistation N2. So resection margin as well as the pathological stage is very important for planning that adjuvant decision is very important. We have to find out that whether negative margin is there, no residual disease, complete resection, all these things is very important. After initial treatment, more than half of patients with resectable non-small cell lung cancer, they will experience the recurrence within 5 years. So around 40 to 50% have remained cancer-free. 50 to 60% patients will recur. So that may be local recurrence or distant recurrence. So overall outcome still need to be improved for patients with resectable NSCLC recurrence. So latest ESMO guidelines have recommended that adjuvant chemotherapy can be considered for patient with resected stage 1B disease and in primary tumor more than 4 centimeter due to clear evidence of benefit. So it's very important in this stage of disease to improve survival in this set of patients that adjuvant chemotherapy is very important. Less meta-analysis have significantly shown that OS benefit from post-operative cisplatin in early stage NSCLC. This meta-analysis has shown that chemotherapy led to improvement in the overall survival with an hazard ratio of 0.89. And absolute benefit is 3.9% and 5.4% at 3 and 5 years respectively. If we see that the forest plot, you will see that for stage 1B to stage 3A, that neoadjuvant chemotherapy had a hazard ratio of 0.87, adjuvant chemo had a hazard ratio of 0.89. So in some group, basically that improvement in the survival. So targeted therapy, now the ADAUR trial that improved DFS in with osimertinib post that resection and post adjuvant chemotherapy patients who are EGFR positive. So here osimertinib versus placebo has shown in 3-year recurrence-free survival almost 80% reduction in the risk of disease recurrence with an hazard ratio of 0.20. It's a significant improvement. So basically that with introduction of EGFR TKI, DFS has significantly improved from 44% in placebo to 90% in EGFR TKI arm at 24 months. It is now also possible to further improve that survival in completely resectable patient. Atijo showed an improvement in DFS as well as overall survival in adjuvant setting. So if you see that the Atijo has showed improvement in survival in adjuvant setting with an staging in patients who had PDL1 more than 1%. At 24 months, 74.6% patient are disease-free versus 61% in the comparator. Lung cancer radiation in 2022. So basically now that advanced technologies have led to the safer treatment, intensity modulator IMRT has shown to improve survival for patients with stage 3 NSCLC and T3 T4 tumor and reduce dose to heart with lower rates of grade 3 or higher pneumonitis. So increasing dose to heart associated with a higher risk of death in stage 3 non-small cell lung cancer. So basically these are all that radiotherapy has significantly that modalities have significantly improved and the toxicity has significantly came down. So there are the different radiation, that image guided radiation therapy that ensures accurate targets coverage for every treatment while reducing the margin needed to cover the tumor is very important, but it's costly, that IGRT. So contemporary RT techniques in stage 3 NSCLC, long-term overall survival results. So it has shown that 60 gray versus 74 gray, that it has
Hello.
Yeah, hope now I'm audible.
Yeah, you are
Yes, sir.
audible.
Please continue.
Okay. So checkpoint inhibition is moving to early stages of unresectable stage 3 NSCLC. This is the specific trial, randomized double-blind placebo-controlled stage in phase 3 trial for consolidation of durvalumab in unresectable NSCLC. That is very important. We have seen that you will see that there is significant if you see that 1 year, that is 83% versus 74%. In that overall survival, and at almost at no. So durvalumab demonstrated that 42.9% overall survival at 5 years in comparison to its historical waves in the unresectable stage 3 non-small cell lung cancer at 5 years is 15 to 25%. So emerging treatment paradigm in non-small cell lung cancer. So these are the targeted therapy and immunotherapy. So basically targeted therapy and immunotherapy works in different ways. So targeted therapies are improving outcomes in advanced NSCLC. So already that my previous speakers have significantly discussed that what is the role of targeted therapy, what are the different targets. So almost 50% of patients with advanced non-squamous NSCLC will have driver mutation that is targetable. So it's very significant that if almost that 1 out of 2 will have some targets, and probably if this targeted therapy becomes affordable, so it will significantly improve survival of our patients. So with chemotherapy, the median PFS is 5 to 7 months, and with EGFR TKI, this has increased to 18.9 months, and with an ALK inhibitor, is 34.8 months. So there are different emerging molecular targets in advanced NSCLC. These are MET exon 14 alteration, which is almost 3 to 5%. Targeted therapy like crizotinib, rate rearrangement, that different targeted therapies are available. NTRK rearrangements in India, that now that entrectinib is available. Others are larotrectinib. HER2 mutations in 2 to 4%, that adotrastuzumab emtansine PDXD is available. And newer targeted agents are being identified, and this will help to improve survival in this subset of patients. So survival outcomes with targeted therapy in advanced NSCLC. So if you see that basically that targeted therapy like that osimertinib has significantly improved in FLAURA, that 39 months of survival. Alectinib in that ALEX trial is 35 months overall survival. That in brigatinib 24 months. So like that only there is significant improvement in immunotherapy in non-small cell lung cancer. Immune checkpoint inhibitors, basically it's use the body's own immune cell to fight the cancer. So there are two different pathways, that CTLA-4 blockade or PD-1 PD-L1. So PD-1 PD-L1 is the most important for lung cancer. Different immune checkpoint inhibitors has been approved. So if you see that from the era of that pembrolizumab, now that lots of new different immunotherapeutic drugs in that 2020 2021 got approval for in different sets of treatment, that in different stages of treatment of that non-small cell or small cell non-small cell or that adeno or squamous cell carcinoma. So basically that immunotherapy survival outcome with immune checkpoint inhibitor. So this is a very easy slide. So you will see that in different sets of treatment, that in different keynote trials have shown that is significantly improved from platinum plus PEM versus platinum PEM pembrolizumab to up to 22 months versus 9 months. Like that only, that there is significant improvement in survival. And checkpoint inhibitors have improved survival in advanced NSCLC. KEYNOTE 024 showed an improved survival in patients with pembro compared to chemotherapy in PD-L1 TPS of more than 50%. Single agent pembrolizumab. Almost 32% patients are alive at 5 years with the use of IO in metastatic NSCLC. So that is significant. and multiple ongoing trials in adjuvant setting of immune checkpoint inhibitors are now ongoing, like that in pembrolizumab, different trials, durvalumab, nivolumab, atezolizumab, all are ongoing trials. So what is new in NSCLC? So basically, that different drugs, newer drugs that are approved in breast cancer are upcoming in NSCLC, like that in different antigen antibody drug conjugates, like ADCs, like TDXD, all these are coming. CAR T-cell therapy is a new era of cancer immunotherapy. So probably it has been started as a standard of care in relapsed refractory that in liquid tumors, lymphoma, or leukemias. Probably that CAR T-cell will show that significant improvement in. It is in the trial setting. Probably in clinical practice, it will come sometimes. So the management landscape is fast changing for non-small cell lung cancer. Newer therapeutics options are gradually coming, and that is improving the survival, especially when that it's detected in early stages. The overall survival has significantly improved in different subtypes with molecular alteration. And basically, with the use of these targeted oral pills, it has significantly eased up that administrations of the drug, and basically patients have that not only that accessibility to the drug is significantly improved, and pulmonologists will play a huge role in early diagnosis, and is very crucial to involve them for early diagnosis of lung cancer. So probably looking into the burden of the disease, which is increasing, we need more and more that one-to-one that discussion with pulmonologists, so that they do something, so that in India, where basically that there is significant higher number of patients diagnosed in advanced stage. So probably if we diagnose in early stage, that survival will probably improve. Thank you. I'll stop here. And if any question, I'm ready. Thank you.
Thank you so much, Dr. Pradeep, for your wonderful talk. Now, I would like to invite Dr. Sudeep Das for next talk on topic exceptional response to osimertinib, EGFRM, metastatic NSCLC.
Thanks to the organizer for giving me this opportunity. Let me make my slides full screen. I hope my slides are full screen, right?
No, sir.
Now?
Yeah, now it's full screen.
Okay. So once again, thanks to organizer for giving me this opportunity. Next couple of minutes, I will be briefly discussing on exceptional response to osimertinib, that is third generation TKI against EGFR mutation and in EGFR mutated metastatic non-small cell lung cancer. So this is our case. So we are not sharing the identity of the patient. Our patient is a 64 years old gentleman who presented with cough, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days, giddiness since 5 to 6 days, weight loss of 5 kg in last 1 month, and regarding personal history, he was non-smoker. Now he was evaluated with a PET CT scan, a mass lesion in the right upper lobe with hilar node and multiple bone metastases were noted. We can appreciate the right upper lobe lesion. There was also hilar node and multiple bone metastases. Then biopsy was performed from the lung mass. On histopathology, it was noted to be adenocarcinoma. On immunohistochemistry, it was positive for TTF1 and NAPSIN A positive, negative for P40. So IHC also confirmed adenocarcinoma. Then molecular analysis was advised, and molecular analysis with limited panel NGS showed that he was EGFR exon 19 mutation positive. And other, as expected, other actionable driver mutations, they were negative. Most of the time, it is a uh, uh, we know that the actionable driver mutations are mutually exclusive most of the time. KRAS was wild type, BRAF was negative, MET exon 14 skip mutation was negative, ALK was negative, ROS1 was negative, HER2 negative, and PDL1 was also negative. On MRI brain, however, there were multiple ring enhancing lesions in cerebellum and cerebral hemisphere with significant perilesional vasogenic edema, as we can see from the MRI films, that the significant edema can be seen on MRI sections. So what is the final diagnosis? The final diagnosis reached was stage 4 non-small cell adenocarcinoma with actionable driver mutation, exon 19 deletion positive, with bone metastasis and multiple brain metastasis. So what about the management of this case? Local radiation therapy for metastasis. And this patient was symptomatic for bone metastasis as well as CNS mets. So he was advised radiation and EGFR TKIs to target exon 19 deletion was also advised. Now, the question was which TKI? If we look at the data of efficacy of different generation of TKI, and if you look at the PFS, then on your extreme left, we have median PFS for gefitinib and erlotinib, somewhere close to 9 to 13 months. Gefitinib was tested in IPAS trial, and that reported as with median PFS of 9.5 months only, the shortest PFS. Optimal trial gives us data about the PFS of erlotinib. The median PFS was 13.1 months. What about the second generation anti-EGFR TKI? Afatinib, not much improvement. The median PFS in Lux Lung 7 trial was 11 months. Okay, there was some meaningful improvement using second generation TKI dacomatinib when it was tested against the standard first generation TKI in Archer 1050 trial, and it showed that not only PFS benefit but also OS benefit, and the PFS with dacomatinib was 14.7 months. To note here, there was statistically significant OS benefit too. Then came the osimertinib, which is the only third generation TKI so far, and it was tested in FLORA trial compared with other first generation TKI, and there was significant PFS as well as statistically significant OS benefit, and in FLORA trial, the PFS was highest so far. It was median PFS was 18.9 months, that is close to 1.5 years. And the overall survival actually was somewhere close to 5 years, so that was phenomenal. Now, some points regarding the CNS activity. We know that most of the first generations TKI, they don't have much reliable CNS activity. Regarding the second generation TKI, there is some data regarding dacomotinib that it has some CNS activity. But the third generation TKI, osimertinib, so far in large randomized control trial, this is the only TKI which has most significant CNS activity and most reliable. So this is some these are some pharmacokinetic properties of osimertinib. When osimertinib was experimented and compared with gefitinib and afatinib, look at the pharmacokinetic properties in this table. The higher mouse brain concentration was achieved with osimertinib than other TKIs. So the brain Cmax was significantly high. You see, it was 2.78 micromole per liter compared to only negligible 0.17. And brain is to plasma Cmax ratio. You'll see that that ratio was 3.41 41 versus 0.1 only. So such is the beautiful blood-brain barrier crossing property of osimertinib and higher concentration of osimertinib in such CNS. So if a patient is presenting to you with upfront CNS metastasis, then osimertinib should be the standard TKI, not the earlier generation TKI. And not only upfront CNS metastasis patients, the FLORA trial also showed that the patient who did not have upfront brain metastasis, uh, the chance of developing brain metastasis was also significantly lower in osimertinib arm. Now, these are also some experimental data showing that the degree of CNS penetration of osimertinib when we actually do scans with osimertinib packed with 11 carbon isotope, and this is MRI, MRI images, and we can appreciate that there is regional distribution and binding of 11C tagged osimertinib on PET parametric images also, and showing total volume of distribution, significant volume of distribution inside CNS. You will see, you can compare the coronal, events on day one, baseline, pre-dose, then PET-2 on day 2, 6 hours post single osimertinib 80 mg dose. Then you look at at day 22, after 21 days of osimertinib 80 mg once daily, and this is the patient 2, day 1, day 2, and day 22. So this is the algorithm which guides you how to treat EGFR mutated non-small cell lung cancer and CNS metastasis. This guideline is as recommended by ESMO NSCLC guideline 2022. And suppose a newly diagnosed EGFR positive non-small cell lung cancer is coming to our clinic. If the patient has brain metastasis, then the very crucial question is he symptomatic or not? If he's symptomatic, then local form of therapy like SRS or surgery should be considered. If patient is asymptomatic, then there is no point to addressing those asymptomatic brain metastasis with local form of therapy. Rather, we can rely on osimertinib because it has highest CNS penetration and efficacy, and probably it can control the CNS disease, and it can delay the local form of therapy in such cases. Now, after progression in CNS on first or second generation EGFR TKI, if the progression site is brain, in such situation also, the big question is the patient symptomatic or not? If no, the patient is not symptomatic, then we should test for T790M mutation. And if the patient is T790M mutation positive, in such cases, of course, osimertinib is the answer. However, if T790M mutation is negative, we all know that um, in absence of T790M mutation, osimertinib is not indicated in second line setting. So even though the patient is progressing in CNS, but in absence of T790M mutation, osimertinib should not be used. In such cases, we have to rely on a local form of therapy like SRS or whole brain RT, and then we can treat the patient with chemotherapy. Now, if the patient has only CNS progressive disease, in such cases, probably after local form of therapy, we can continue with TKI. But if the patient has both CNS as well as systemic progressive disease, then there is no point continuing continuing the same TKI. After the local form of therapy, we should continue treat the patient with chemotherapy. This is the data of landmark phase 3 trial, FLORA trial. And this is the subgroup data of patients regarding CNS outcome. So in FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry versus EGFR TKI comparator. So, as I was mentioning in my previous slides that in FLORA trial, there was benefit in both the groups who had de novo upfront CNS metastasis and those patients who did not have upfront CNS metastasis. So, with patients with known or treated CNS metastasis, the median PFS was 15.2 months in favor of osimertinib versus only 9.6 months. Look at the hazard ratio. Very impressive hazard ratio. It's 0.47. And the similar kind of benefit you also achieve in patients without CNS metastasis. Median PFS 19.1 months for osimertinib versus 10.9 months for standard of care. Hazard ratio, again, very impressively 0.46, and both these hazard ratios were statistically significant. So now, if you analyze the data of FLORA trial and brain outcomes, you will see that in to do the subgroup analysis of different trials using afatinib, dacomitinib, and osimertinib. The afatinib data comes from LUX-Lung 3 and 6. That was versus chemotherapy, and LUX-Lung 7 was versus gefitinib. Patient population, baseline asymptomatic brain metastasis patients were allowed in LUX-Lung trials, and the number was in LUX-Lung 3 and 6, it was 81. For LUX-Lung 7, the number was 51. Now, the response rate was in LUX-Lung 3, it was 70 versus 20, and LUX-Lung 6, it was 75 versus 28. The median CNS PFS was 8.2 months versus 5.4 months. What about Lux Lung 7, when you are comparing afatinib with gefitinib versus gefitinib, then this PFS difference was non-significant. Actually, PFS was same, 7.2 months versus 7.4 months, P value of 0.93. So the take-home message is that when you compare the CNS activity of afatinib versus gefitinib in Lux Lung 7, you will see there is no difference in median CNS PFS. However, you achieve some median CNS PFS benefit with afatinib when you compare with chemotherapy in Lux Lung 3 and 6 trials. But we all know that chemotherapy is no way is the standard of care in any actionable driver mutation positive lung cancer. What about dacomatinib, Archer 1050? Brain metastasis excluded in this trial. However, there was a series of prospective series of dacomatinib published from by Dr. Vibhash et al. They showed that there was some degree of benefit uh, with in CNS disease also with dacomatinib, but that was non-randomized and that was single arm prospective data. It was not in a randomized controlled trial setting. Now the best quality data for in favor of osimertinib as far as CNS activity is concerned, that comes from a phase 3 randomized controlled trial, that is FLORA trial. When your comparator was standard TKI like gefitinib or erlotinib, baseline asymptomatic CNS metastasis patients were actually allowed in this trial, and there was a good number of patients, so such patients, 116, and the median CNS PFS rates were 15.2 months in favor of osimertinib versus 9.6 months uh, for first generation TKI like gefitinib or erlotinib. And this difference was statistically significant with a hazard ratio of 0.47. So, what are the take-home messages? Intracranial or CNS response was not assessed in Lux Lung 3, 6, or 7. Systemic clinical benefit was observed with afatinib versus chemotherapy, but not versus gefitinib. Systemic and CNS clinical benefit were observed with osimertinib versus gefitinib and erlotinib. Patients with brain metastasis were excluded from the Archer 1050 dacomatinib trial. Data on brain metastasis were not generated in either the erlotinib or gefitinib global clinical trial program. So this patient, she had bone metastasis as well as brain metastasis. He was offered palliative radiotherapy to spine for backache with zoledronic acid. For brain metastasis, patient he was offered radiotherapy to brain, but he denied to take brain RT and wanted to see later. He started on the first line TKI, that is a best third generation TKI available, osimertinib 80 mg daily. Now, these are the follow-up PET scan images taken in March 2021. Right upper lobe lesion encasing the right upper lobe bronchus. You can appreciate the change. The prime at the baseline SUV max was 19. Now in the response assessment PET scan, SUV has come down to 3.4. There's a morphological response to almost 50% shrinkage from maximum diameter of 4.1 centimeter to 2.2 centimeter size. We even achieved reduction in the right hilar and paratracheal nodes from 2.4 centimeter size. It reduced to 6.6 centimeter, and SUV max reduced from 7.9 to 1.9. So, if we discuss the effectiveness of TKIs in brain metastasis, the CNS, response rate, objective response rate will be somewhere as high as 66% for osimertinib, and that was compared to the first generation TKI like erlotinib and gefitinib, it was only 43%. What about CNS disease control rate? The CNS disease control rate with osimertinib was as high as 90%. Look at the brain MRI images. These are the follow-up brain MRI images, and there was amazing result. Almost there was a complete response neurologically radiologically on the we can appreciate on MRI films. Complete resolution of brain lesions on MRI brain. No additional intervention was needed. So radiotherapy we could refer for this patient. Now, some case reports on osimertinib and brain metastasis. This is a 53-year-old patient relapsed while being on chemotherapy for stage 3A. Subsequent scans revealed pretracheal nodal hypermetabolism, and on repeat brain MRI, she was found to have multiple brain mets, including 3.1 centimeter inferior Vermean metastasis with surrounding edema. Osimertinib was started at 80 mg daily, and patient complained of ataxia, worsened significantly in the following days, and was scheduled for craniotomy and tumor resection the following week. Then the patient was started osimertinib, decrease in size of lesion, resolution of symptoms, and complete resolution of lesions was noted. Another case report of osimertinib and brain metastasis, similar kind of success story. Another study demonstrated efficacy in CNS metastasis. Here, the median IPFS was 11.8 months. The conclusion of the authors were osimertinib demonstrated high efficacy on brain metastasis. All trial arms displayed a significant decrease in the number and diameter of target lesion. So these are the serial scans of our patient. On your left, you can see in the November 2021, and then on your right, April 2022, almost complete response. So what are the key points and food for thought from our case? Radiotherapy for brain not needed. Still patient had complete resolution of brain metastasis, almost complete resolution of primary disease and nodes. No or any adverse events were reported in this patient. Patient remains progression free even after 19 months after initiating osimertinib. Is asymptomatic and fully active. Goes for morning walks and in fact yoga sessions, leading a normal life. So now excellent response to osimertinib. Are such tumors different? Do you have any biomarkers to predict such excellent response? If you see the forest plot of flora, you will notice that there are some difference in efficacy of osimertinib in EGFR exon 19 deletion versus exon 21 L858R. It seems that the efficacy of osimertinib is more pronounced in exon 19 deletion compared to exon 21. So with this, I want to thank you all for your patient listening. I'll be happy if you have any questions I can take. Thank you.
Thank you so much, Dr. Sudeep, for your wonderful talk. Now, I would like to invite Dr. Amit Badola for the next talk on Advanced EGFRM NSCLC, a evidence-based review of targeted therapies.
Thank you, organizer, for giving me this opportunity. I think I'm audible, right?
Yeah, sir, you are audible.
Can you, and my slides are visible, okay?
Yeah, it's visible.
Okay. So first of all, thank you, organizer, for giving me this opportunity. And my topic is evidence-based review of targeted therapy in EGFR mutation, lung cancer, non-small cell lung cancer. I think my job is already half done by previous speakers. So I will be try to bit concise. Yeah. So it's the epidemiology is already covered, and we know that lung cancer is globally the most common cancer in terms of mortality, and in terms of incidence, it's ranked second. This is a bit relevant slide for us because, as we know, that majority of the lung cancer patients present in a very advanced stage. Like in this slide, it is showing around 65%, but in our clinical practice, it's more than that, around 70 to 80% of lung cancer present in a very advanced stage. And as the age advances, the survival also decreases. Like from stage 1, the survival is around 90%, the 5-year overall survival, and it came down to around 13% for stage 3C. I'm really happy to see the changes in lung cancer treatment in last few years. And now we know that for the more than 50% of the stage 4 non-small cell lung cancer, we have biomarkers. They can be a predictive biomarkers for a specific therapy, and some biomarkers have a prognostic significance. So almost 36% patients are having no biomarkers where we don't have any treatment. Otherwise, for most of the patients, we have some mutation or PD-L1 expression. So in this chart, we are seeing that 25%, the most common one is KRAS, followed by the EGFR mutation. But I think for Asian population, it is more than that. It is around 30 to 40%, the expression of EGFR mutation, followed by ALK or ROS, RET. The number is endless now. As our first speaker, they told about the testing methodology. I just want to be brief on that. Nowadays, I think majority of the center is doing hotspot NGS testing. But if you want to test it individually, so EGFR can be tested by PCR. For ALK, ISC and FISH can be done. ISC is as effective as sensitive as FISH. For the Roche, ISC is screening. We have to confirm it by FISH, and PD-L1 we have only ISC. So our topic is basically EGFR mutation, non-small cell lung cancer, and we know that the tyrosine kinase of EGFR receptor is the most target site for all these TKI, and it constitutes this exon 18, 19, 20, and 21. The most common is actually exon 19 deletion and exon 21 point mutation, which is L858R. And if you'll see the prevalence of EGFR mutation, it's same. It does not changes very much from stage 1 to stage 4. Though it changes with the region. Like in Asian population, the incidence is quite high compared to the US and European population. So in Asia, Asian population, the prevalence is around 30 to 40, while in Caucasian, it is around 10 to 20%. And we all know that now EGFR testing is recommended even in early stage lung cancer. And now it is actually pre-operative also we need it. It's not like in post-operative adjuvant setting. Whenever you get the tissue, you have to do all this molecular test. So basically, this talk will more focus towards osimertinib, which is a third generation TKI, and it's like our previous speaker told, it is having a good brain blood barrier penetration. it bind with the tyrosine kinase domain irreversibly, and it is effective in T790M resistant mutation, which is seen in 50% of the patient who is receiving first generation TKI. So I'll just cover the osimertinib trials. One was the landmark trial FLORA, which was a phase 3 trial in de novo metastatic non-small lung cancer patients. Majority of them in stage 4 and advanced stage 3 also they have included in this, and they randomized patient into osimertinib versus the first generation standard of care TKI. And the primary endpoint was progression-free survival, and they allowed the crossover, which is important to note. And if you see, around 19% patient is having a baseline brain metastasis. It may be asymptomatic or asymptomatic. As this slide was shown by a previous expert also, which is showing that the progression-free survival by investigator assessment, it was around 19 months compared to 10 months, having a wonderful hazard ratio of 0.46. That means a reduction of progression by osimertinib was around 54%. And the effect was on in all subgroup. There's one catch here, though there's a PFS advantage in the all group, but the overall survival advantage, I'll show you the osimertinib is also having the overall survival advantage, but the survival in this L858R exon 21 mutation, it is not that significant. This is the objective response rate, which is crossing the 80%, and the duration of response is also around 18 months. This is the overall survival, which is, osimertinib touched that magical p-value, and the overall survival was around 39 months, 38.6 versus 31.8, and the p-value was significant. It is well tolerated compared to the first and second generation AKI, and having a very, very less grade 3 and grade 4 toxicity. Yes, it has some toxicity in the terms of stomatitis, paranoia, rashes, but it is well tolerated compared to the first and second generation TKI. So based on the FLORA trial, it's now the history. I think all the center who can, where the patient can afford, they are actually using osimertinib as a first-line therapy in all patients, as it is not only increasing the progression-free survival, but also improving the overall survival. As our previous speaker told, the osimertinib is having a CNS activity, and we know that the patient who is having CNS disease at baseline, they do worse compared to other patients. While osimertinib improve, if you see the PFS in without CNS metastasis, the 19-month PFS. But of a patient who is having baseline CNS disease, the PFS is 15 months, and it is better compared to the standard of care, which is 9.6 months. The hazard is 0.47. In full set analysis, the median CNS PFS was not reached actually in osimertinib arm, and for the standard of care, it was 13.9. So there's no head-to-head comparison of osimertinib with second generation TKI, though we have a comparison with the first generation TKI. We cannot compare actually both trials, cross trials, but if you'll see in Archer 1050 trial, the median PFS was around 14 months, and we lost around 25% patient in the first 6 months. While in FLORA trial, the both arms start separating early, and I think that is converting into more PFS benefit in FLORA trial. And this overall survival, again, it didn't reach to that magical p-value, while, as I discussed early, in FLORA trial, osimertinib did that. But as I told you earlier, if you'll see the forest plot of osimertinib, there's no overall survival benefit in L858R. While if you'll see in the dacomitinib arm, it was showing the OS benefit in L858R. So dacomitinib people are actually promoting in this on the basis of this data, but I'll say the number of patients was very less. And compared to osimertinib, I'll show you the toxicity. The dacomitinib is having a significant toxicity. If you compare with afatinib, the Lung 7, the PFS of afatinib is around 11 months. It's less than your its competitor second generation TKI dacomitinib, which is less than that. And it is also not achieving the overall survival advantage compared to the first generation TKI. This is the important slide which I want to focus on. If you compare with the second generation TKI, the osimertinib is having a very, very less side effect. And I think on the other member will also agree with that. It is well tolerated compared to, and we don't require actually the dose reduction as we usually do with afatinib and dacomitinib. Another important point, if anybody want to argue with that, why we want to start with the osimertinib, we can start with the first generation TKI and then we can switch to the third generation TKI. So my argument with this is, in competitor arm of FLORA trial, there is actually switching, and around 47% patients received a third generation TKI. But the problem is, all patients did not receive a second generation TKI. So if we'll start patient with the first generation TKI, we are almost losing 30% patients who could not receive a better treatment upfront. So this is actually the the standard of care arm of FLORA, where it is showing that only 47% patients received osimertinib, while 30% patients we lost after first line therapy. And this is the latest one, the FLORA 2 trial. And I think it's now majority of centers are practicing this also, where we are combining osimertinib with the chemotherapy compared to osimertinib. And if you see the progression-free survival, it's magical. It's touching to 29 months. And if we see the investigator assessment PFS, it is around 25 months. And if we are seeing blind independent central review, it is around 29 months. Though we does not have any overall survival data yet, but this data looks very promising. And the conclusion with this by the investigator of FLORA 2 that as it is showing the first time we are seeing in EGFR TKI with combining with the chemotherapy, we are getting the progression-free survival of more than 2 years. And we are also hoping that it will convert into the overall survival. We all know that it's now like 4-5 years where osimertinib is a category 1 evidence for EGFR mutation, metastatic lung cancer, non-small cell lung cancer. So the conclusion, for the first time, we know that now it's not new now. It's now history that EGFR TKI, the third generation osimertinib showed not only PFS but overall survival benefit. Compared to the first generation, it is showing 19 months of PFS and overall survival of around more than 3 years. It is having a less toxicity and having a good brain penetration. So we know that osimertinib is a standard of care, and now we can incorporate chemotherapy without any alarming side effects. So this is all from my side. Thank you very much.
Thank you, Dr. Amit, for wonderful talk. Thank you, everyone, for giving wonderful talk on given topics. Good night to everyone. Technical team, please close the meeting.